Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast is to bring you short educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment and the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job in caring for people living with dementia and connecting them and their care partners to the things they need. Well, welcome, Dr. Elena Portacolone, friend and colleague here at UCSF. I'm Anna Chodos, the host of Dementia Care on Air. Mm-hmm. And thank you for joining me to have a conversation about your work, which has really inspired me. And I'm just so amazed at the work that you've done with older adults living alone, but also living alone with cognitive impairment. So thank you for joining me to talk a little bit about that work and also how we can help other providers like myself and other folks in primary care make the most of the work that they're doing with older adults with cognitive impairment and do better by them. So I will let you introduce yourself.
Sure. So I am an associate professor of sociology at the Institute for Health and Aging at UCSF. And I received my PhD in sociology at UCSF and a master in public health and a master in business administration at UC Berkeley. And then I studied in Italy, and I was born in Italy.
How do you describe the focus of your work now?
I'm especially interested in understanding how to improve the care that older adults with cognitive impairment living alone receive, especially with emphasis on older adults from communities of color.
How did you get interested in that group?
Well, I've always been very interested, and I don't know why, in the support of older adults. I've always been extremely fulfilled since my 20s. Now I'm 53. Just gave me really big satisfaction caring for older adults, and then when I started doing some research, I became attracted towards studying older adults living alone. Maybe because I live alone, and also maybe because my father died suddenly when he was living alone during the week abroad, and also my grandmas were living alone. So I think that this living alone just grew on me. And then when I started spending time with over 40 older adults here in San Francisco, I noticed that most of them had cognitive impairment. They forgot who I was. They looked surprised when I arrived. And so I became very interested in supporting older adults living alone with cognitive impairment, because very little was known at the time about them and about their needs. And it's clear that those who live alone in older age and have cognitive impairment have great needs for professional support.
Would you say it's a common scenario? Because actually your personal examples suggest it's pretty common for people to live alone.
Yes, it's pretty common. So, for example, in the US, 27% of adults age 16 over live alone.
27%.
27%. And around 14 million people. And regarding older adults living alone with cognitive impairment, our group estimated that there are 4.3 million older adults living alone with cognitive impairment here in the US.
So in terms of medical care, if people are being seen in primary care or another healthcare setting, is it important to know if an older person lives alone? Like, should we be asking about it?
So, yes, it's very important that providers, medical providers, pay attention to the living arrangement of their old patients, because living alone is often a marker for living alone in older age is often a marker for limited social networks and for need for professional services. So it's very important that providers pay attention to whether their patients live alone or not. And if they live alone, they should understand a bit better their arrangement. The ideal is that they go and visit them in their homes at least once to understand the lay of the land.
I love that suggestion. Yeah, it's a cornerstone of a lot of geriatrics practices that they'll do at least one home visit, but it's a really good point that actually seeing it might be really informative, not just asking about it. So it's a marker for potentially some needs or vulnerabilities. Yeah. I know you've also done scholarship and really put out there this idea of precarity in older age. Can you say a little bit more about that or help people know what it means what precarity means for these older adults? Yeah, sure. And also I can maybe tie to why for providers could be useful this idea of precarity. So when I spent time, when I interviewed around 47 older adults living alone in San Francisco, I had this sense of chronic insecurity that most of my participants experience. And that is chronic insecurity, or another word is precarity, stemmed from different reasons. One is that these persons felt that it was really important for them to be independent, to show that they can do it by themselves. So back to paying attention to your patient, whether they live alone or not, another thing that you can consider is that if your patient lives alone, he or she might hide a little bit challenges that they have, because they may be afraid that you might remove them from their home. So they may give you a more positive outlook than a patient who is living with someone. And because the patient who lives with someone maybe feels safer knowing that they can keep on living in their homes. So there is this idea that it's really important to be independent and to prove that you can do it on your own. Then the second marker of this precarity is that the person that I spent time with had problems accessing services. Sometimes transportation was difficult, remembering appointment, organizing appointments was difficult. And then the home care aides that are a very important resource for those who live alone here in the US are only available to those who are on Medicaid, which is only a small portion of older adults, and then the precarity also came from the fact that these persons were struggling with different challenges at the personal level, often having less money, less resources, less status, less friends, because friends or also significant others might have died or might be too sick, to go out or help each other. And so there is this shrinking of resources, energy within a system where the system is not really geared towards supporting the older adults. And the older adults can give for granted that it's important to be independent. And so then the older adult living alone, start facing challenges that become bigger and bigger as
as the years go by. And they hide the challenges to others, especially to the provider.
I think what really sticks with me is what you point out about this strong valuation of being independent actually being kind of a problem or a risk factor for higher precarity, because you have these internal barriers to admitting that maybe more support is needed or bringing it up or being open about it, which I think we can all understand. And it's not to point out that the person themselves has a weakness or anything like that, but more or a problem per se, but just that it's a real barrier, that we really, really value independence. And what that means is you cannot meaningfully discuss needing support in some situations. The other thing I know you point out sometimes is how cognitive impairment specifically may make that even more challenging, because people may not have insight or may be aware that they're even more vulnerable to losing that independence if they make it really known that they need that support. Am I getting that right?
Yeah, Anna, you're getting it totally right. And at the same time, also, provider can pierce that wall of independence or wanting to hide struggles by really being attuned, spending time being attuned with the participant needs. Visiting in their homes at least once makes a really big difference. I'm thinking about some of the stories that participants in my research talked about, and just creating this atmosphere of trust and talking very clearly about the provider mission to support the patient keep on living in their homes and making sure that they have a good life. So I think it's totally possible to pierce it through. It just takes some extra time and effort.
I love the idea that we would feel empowered to have a better therapeutic alliance with someone, and I know that's your current focus of work, is how providers can have moments of improved therapeutic alliance with people living with cognitive impairment or dementia living alone. And I'm wondering if we can dig into that a little bit so that maybe people, if they're listening, could take home some tips.
Yeah, I think that being sensitive, well, number one, seeing whether the person lives alone or not. Then, if the person lives alone, the provider should pay particular attention whether the person exhibits some forms of memory loss or problems with thinking, and then probably it's good for the provider to diagnose the cognitive impairment, if any, and use this moment, the moment of the diagnosis is a really wonderful opportunity to develop or reinforce a therapeutic alliance with the patient, because I know some of the participants in my research said that they were really concerned about the memory loss, and they were even more confused if when the physician didn't talk about the memory loss or did some tests and then didn't talk about the results of the tests, and to the point that some participants even spent time in the library to try to understand what they had, because they were so concerned about not knowing what was going on with them. So I think opening the diagnosis is a way to open up the box, speak and talk about the diagnosis. So what is that? What the diagnosis entails, and then the key is not to use the diagnosis only in a medical way. So you got a diagnosis and I'll see you in 6 months, but but use the diagnosis to put together a team of different providers, if possible, following the person who lives alone with cognitive impairment. Because during the diagnosis, the person is very open. So I think there is this window of openness and possibilities and opportunities. And so it's really important to make the best out of that window.
Well, that's a really good point, that the moment of disclosure or diagnosis in and of itself is a more potent moment than other times. I know you have some quotes from some of your participants that kind of illustrate some of this. I don't know if you have any that you want to share.
Well, for example, a man who was diagnosed with Alzheimer's disease said, "The neurologist listened very carefully for a good long time, and then she began to suggest things that might work for me, and I find that very comforting." And I think that this person even said that when he received the diagnosis, he was with his daughters, and the neurologist did it in such a caring way, and it just managed to have the daughters open up about their concerns. The person himself with the diagnosis open up about his concerns, that he felt like clapping, or I think they all clapped at the end. So that was really an incredible moment. Or another woman that she was really concerned that maybe she had to have some difficult procedure related to her cognitive impairment. When she heard that she was not going to have that procedure, she felt very relieved, and she said, and just, I'm using my memory, I would have kissed him right now. I would have kissed the neurologist right now. So it's really an important moment where the person is extremely open, and so then that's the moment where a really strong connection, a deep connection can be created. But then, so the seed is planted during the diagnosis, but then we need to water it, and so I think it's really important. And then the providers meets with the patient maybe really soon after the diagnosis, maybe once a week for a little bit, in order to stabilize that connection, and also bring, of course, the provider doesn't have much time, so to bring also other persons to keep on creating this sense of support to the person living alone.
Well, that's a new life goal, to get someone to clap after I give them a diagnosis. That is definitely high praise. Also, it's a really nice quote because it shows how a diagnosis can be a moment of relief, when I think for us, sometimes as providers, it's stressful because you feel like you're giving bad news, but that there's a positive side to just simply knowing what's going on and having it named and figured out. It also sounds like a big part of that for this participant, which maybe I'm reading too much into it, is having a plan. I think another thing that comes up a lot or I hear come up a lot around concerns about dementia diagnosis are the fact that, quote unquote, there's nothing you can do. So Dementia CareAware itself really wants to help people feel more comfortable screening more regularly for dementia, and then working through the next steps and trying to get to diagnosis. So I'm wondering if, even at a moment of screening, they have some symptoms or they have some evidence of functional need. Mm-hmm. It seems like living alone would maybe even be relevant then.
Yeah, very much so. Yeah, because it's important that the provider realizes that the person with the cognitive impairment who lives alone has extra needs, because often this person doesn't have anybody living with him or her. Mm-hmm. So that's an extra need. And often this person might have a caregiver. The caregiver may be not living nearby. The person also the patient may not have any caregivers. So yeah, the living alone when a person has dementia is really, for me, it's the most important marker, but I'm totally biased. But it really creates a total different situation from the person who lives with others.
And I think you've talked to providers about some of those challenges. Are any of them ones that you can share or remember? Like, I'm sure a lot of us who do primary care or sort of outpatient care are aware that it just feels harder to get information about a living situation. So maybe that really underscores that if we can, we should do a home visit.
Yeah.
I just try to get creative. Like I call, if they go to regular day program, sort of call that program and see what they've noticed or what collateral they can provide. Or if they're willing to give me names or numbers of any friends, trying to get some additional collateral. But it does always feel like a little harder, clearly harder than if somebody comes with someone who lives with them or comes with somebody who sees them really often. It feels harder to just even get basic information about function and how they're doing. I guess I'm just sort of probing to see if there's other pearls you can share about like what challenges we might have in even getting information.
Well, there are challenges in getting the information. Also, the person who live alone may be less likely to seek a diagnosis, to go to see a provider. So just the fact that a person with cognitive impairment living alone, that you're giving a diagnosis to someone who lives alone is a miracle in itself. And so I think it's important that the provider cherishes this miracle, and it's a miracle, but it's also maybe, I don't know if it's the right word, but also it's a big responsibility, because then if the person lives alone, the person has less support. If the person is not on Medicaid, doesn't qualify for home care aids, and so the diagnosis of a person who lives alone with cognitive impairment come with extra responsibilities, and maybe a strategy for providers is to strategize with the care team, with other colleagues, on how to work when this miracle of giving a diagnosis of someone who lives alone, a diagnosis of cognitive impairment to someone who lives alone occurs, and how to create this network of support. And like you said, Anna, I think that the key is really to organize a home visit if possible, because the home visit has different advantages. One, the provider gets a good idea of the situation of the person and can go a bit deeper. And two, the more trust is established between the provider and the patient. The patient is often amazed by the provider went the extra miles to go and visit him or her in the home, and so trusts the provider more. And then also the provider, by seeing the home, can think more in a more in-depth way on what type of services this person may require. And especially, I think a really important item to consider is that if the provider needs to remove the driver license from the patient with cognitive impairment who lives alone, then that really needs some extra care, because by removing the driving license, then the provider can become the enemy, and so tarnishes the trust. So one more reason to go and visit the person in their homes to keep on creating this trust and not being seen as an enemy. And two, it's really important that then the provider maybe works with with the care team in order to understand how to support the patient who lives alone, just lost a driving license, just got a diagnosis of cognitive impairment, organizes his or her transportation, and how he or she can get food, and to make sure that they keep on being able to see their friends, going to whatever, mass or whatever, or play games, so then the person keeps on being connected.
I guess I just wanted to comment that I know I've often had other reasons to order like home health, which is, a clinical team of either nurses or physical therapists and occupational therapists, sometimes a home aide and social worker, to see the person in their home. And if I can't do the home visit myself, and I'll often like read those notes like a novel, and just really look at the details to understand how they might be doing. So I sort of try to find other ways to use eyes and ears in the community if I can't go out myself. Because I know just practical time-wise, it can be really hard to figure out like when to do a home visit. And often it's on my own time, and then that gets, challenging. And sometimes, it may feel like a lot, but it depends on your relationship with Adult Protective Services. But sometimes I've called them to pay a home visit and explained that what I'm hoping for, that they can just assess the situation, that it's hard for me to tell. And I think Adult Protective Services is differently resourced in different places and has different bandwidth and all of that. But I guess I just wanted to bring up different ways that I think of, quote unquote, the team in the community, because from my actual outpatient clinic, I don't have a lot of those resources and necessarily that flexibility in my own schedule. And I love how elevated you make everything, that it's like this cherishable miracle that we've made this diagnosis. And it's, to me, not hyperbole, you're making a great point that it's actually, this is a really important moment. I think what we were starting to get at too, though, is maybe we're kind of limited sometimes as healthcare providers. So I know in some ways that this has really motivated you to think about policy and bigger issues affecting the quality of life and the lived realities of people with cognitive impairment living alone. Do you want to just briefly mention some of the highlights of how we should be thinking about policy and maybe structural changes that might make a difference?
Yeah, thank you, Anna. Yeah, building on the miracle, of the diagnosis, I think that policy-wise, my dream would be that once a person in the U.S. is diagnosed with cognitive impairment and lives alone, then this person automatically receives a subsidized home care aid independently from their income. So that would be my dream. That this type of policy is already active in Denmark, for example, and I. Because for medical providers, it's just the responsibilities to support all patients living alone with cognitive impairment. There are so many items to be concerned about when a patient. When one of your patients live alone and has cognitive impairment, that is really important to have a care team. And I think that one of the most important persons in this care team is the home care aide. A home care aide, well paid and well trained in the care of person with cognitive impairment, And so in terms of policy, I am working with a group of policy experts to understand what are the best mechanisms to ensure that home care aides are better paid, are a more attractive job in the United States, and that they are paired with appropriately in a culturally relevant ways with older adults who live alone with cognitive impairment. It's really important that there is language concordance as well as sometimes race and ethnicity concordance is very important, and so we are looking at understanding how to, number one, make the diagnosis an opportunity to create these therapeutic alliances like we've been talking about, and then how to provide an array of services subsidized to any older adult who lives alone and is diagnosed with cognitive impairment. So, and at the same time, it's important that we don't only focus on older adults with cognitive impairment living alone policy-wise, but we also need to create policies that also support unpaid caregivers to older adults with cognitive impairment, because also they are very much penalized. I think it would be great to find a way to subsidize caregivers as well as friends, new caregivers, people that wouldn't have caregiver normally, to be paid to support their neighbors or their friends who are living alone and they have cognitive impairment.
Couldn't say it better myself. I think just the amount you're underscoring how important the support in the home is when it's needed, if it's needed, and some way to ensure that that's accessible in a really broad way. So I think I'm going to round up our conversation with a question that I know you often ask people, which is the magic wand question. So if we had a magic wand and we could wave it, what problem would we solve?
Well, the word that has been popping up in my mind is the word belonging, the sense of belonging. So I think my magic wand would be to really create, to ensure that the person who lives alone has cognitive impairment keeps on feeling a sense of belonging with their community, their neighborhood, their providers. So my magic wand is to have a way by which the provider gives a diagnosis, identify the person who lives alone and has cognitive impairment, gives a diagnosis in a way that fosters this therapeutic alliance, and then gives these provides the support of a strong and motivated and well-paid and well-trained support team, so then the person who lives alone with cognitive impairment keeps on feeling a deep sense of belonging to the community.
How did I not anticipate such a beautiful answer? That was really beautiful. I think that's a wonderful way to think about how we can all generally approach this issue better, which is, yes, people live with dementia, and they live with dementia or cognitive impairment in all sorts of situations, but they're all a part of our community and still a part of our responsibility as neighbors and community members. Thank you so much for that. Thank you for sharing your work with us. I'm so grateful and really look forward to all the work you're still going to do.
Thank you. Grazie.
Ciao.
Ciao.
Thank you for listening and to our wonderful guests. And a big thank you to our administrator and everything doer, Rita Archikova. Also, thank you to our audio editor and voice specialist, Lisa Costello. And we want to make sure you know you can get CE, CME, and MOC credits if you go to our website and click through to the podcast page, where you can do a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of the Dementia CareWare team. If you want to learn more, please visit our website, dementiacareware.org.